Let us look now at some of the other problems around the knee, and one of these is patellar tendonitis. Patellar tendonitis is often called jumper's knee as it is commonly irritated. The patellar tendon is commonly irritated by repetitive high loading of the knee, especially where the quadriceps are not strong enough to control this movement. The common sites of patellar tendonitis are around the inferior pole of the patella, the insertion of the tendon at the tibial tuberosity as seen in the diagram. It commonly develops in consistent overloading of the tendon with micro tears, which then may progress to macro tears. Cysts are commonly seen and may irritate the condition further. How do these people present? They often have a history of overuse and commonly with hard surfaces, so an overloaded position with a hard surface. They may have had a history of previous injury within the area, and this may be acute injury on top of a chronic history. They often have pain on direct palpation of those 2 points, or if not in non-weight bearing, definitely with loading. There may be a small amount of swelling around the area, and the inflammatory sign may be the heat as well. On MRI, may reveal a cyst at the inferior pole. Check first of all and ask the client about their training surfaces, the type of footwear that they've been using, and the frequency of loading. Management of patellar tendonitis is with the normal Rice or Price regime, and reduction of shock, such as using appropriate modification of their shoes and surfaces in which they train on. Pro-inflammatory techniques such as frictions are very useful around the patellar tendon, and other electrotherapy. Pain relief as before, TENS and interferential where appropriate, and rehabilitation in a controlled. And failure of conservative treatment can be followed up with either steroid injection, autologous blood, or etc., or surgery. Another common condition that may be seen around the patellofemoral area or anterior knee is called Osgood-Schlatter's disease. It is a swelling of the epiphysis where the patellar tendon joins on to the tibial tuberosity. It is commonly seen in young children, particularly boys having had a recent growth spurt, and there's often a history of repeated high stress at the quadriceps insertion. So those young boys playing a lot of sport, particularly bowling and cricket, a lot of kicking in football, may develop Osgood-Schlatter's. The epiphyseal plate becomes mobile and overacting, which in itself causes pain acutely over the area. Too much activity and weight training in children are some of the identified factors which contribute towards this condition. How do these patients present? They will often have pain localised to the tibial tuberosity of a dull and achy nature, indicating the inflammatory component. There is pain on loaded knee flexion, and if they continue activity, this is often aggravated more. Palpation of the knee around the tibial tuberosity is painful, and it may actually feel mobile where the epiphyseal plate is becoming loose. An X-ray can confirm this diagnosis. Management of this condition has to be qualified rest. They may carry on certain non-weight bearing or relative partial weight bearing exercises to maintain their fitness. Ice, interferential and other electrotherapy techniques may help, and there is a obvious debate over the use of ultrasound where there is a osteological dysfunction. Strapping may be allowed to help continue activity. It's important not to give any sort of strenuous quadriceps strengthening exercises, as this will only aggravate the condition further, causing the epiphyseal area to be more mobile. This will consider other injuries, more meniscal and ligamentous around the knee joint. You will have considered during the anatomy, the anatomy and mechanics of the medial and lateral menisci. how the collagen fibres of these structures radiate around and circumferentially. They have very little blood supply, particularly it will be appropriate, that there will be blood supply in the outer 1/3, but this doesn't persist into the rest of the menisci, and so there is a heavy implication here for repair. The menisci themselves are aneural. They have no pain receptors themselves, and therefore the clinical presentation of meniscal injuries is often through locking giving way. And if there is associated pain, this is perhaps due to some other soft tissue injury. The menisci themselves are stabilised by the little coronary ligaments and the meniscofemoral ligaments, which are extremely sensitive, and this may be where the pain arises. Medial meniscus blends with the MCL, and so can become less mobile during movements of the knee, and on impact becomes more susceptible to injury. The lateral meniscus is more prone to degeneration due to the loading, as discussed in the osteoarthritic section. The function of the menisci generally is to shock absorb and help to dissipate loads of the knee and increase the congruency of the tibiofemoral joint itself, and they also aid with the distribution of lubrication throughout the joint. What is the mechanism of meniscal injuries? Movements of the menisci occur during flexion, extension and rotation. Injury normally occurs during extension and rotation, as loads applied to each meniscus may be in the opposite direction. So with extension and lateral rotation, the medial meniscus is often injured. With extension and medial rotation, the lateral meniscus is most commonly injured, although the actual incidence is less common, as I said before, because of it's less firmly bound down and so can move out of the way. Usually it's a non-contact situation during side-to-side or cutting manoeuvres. Occupations that involved sustained squatting or kneeling can also compress the menisci, as shown in the diagram below. So plumbers may have meniscal injuries. What are the types of meniscal tear that may occur? The types of meniscal tear depend on the degree of degeneration and the mode of injury, and some of the examples of tears can be seen in the diagram. There may be complete or partial radial tears, longitudinal tears, double longitudinal tears, flaps and cleavage of the cartilage. The area where the meniscus is injured and the extent is very dependent on the outcome of conservative treatment and as to whether surgical treatment is indicated. Clinically, these patients present most commonly with a specific history. Pain is usually emanating, as mentioned before, from the coronary and meniscofemoral ligaments. The torn fragment, if there is one, may become stuck within the tibiofemoral joint and lead to locking, particularly during extension positions in the close packed position. And it is important to differentiate between true locking and pseudo locking. And true locking is where the joint is locked and the patient is unable themselves to unlock the knee joint. Pseudo locking is where the knee locks but the patient can wriggle their joint free. So true locking is a sign of meniscal torn fragment becoming lodged within the knee. Giving way may occur and is a sign of instability and loss of stability due to the tear within the meniscus. There is commonly effusion indicating that trauma has occurred, and on examination, positive meniscal tests such as McMurray's and Apley's would be appropriate. MRI is a useful Here you can see some MRIs of the knee joint itself with the menisci torn on the. So how do we manage meniscal tears? Manipulative reduction under anaesthetic or otherwise may be possible to allow temporary restoration of function. Some small peripheral tears may be treated conservatively, especially if they are within that outer 1/3 vascular zone, and these will be managed with the appropriate pain management, but also rehab as well. If the tear is within the vascular zone, then a repair may be appropriate, and if it stretches into the avascular zone, excision may be appropriate via arthroscopy. Most commonly, the post-op complications are with removal. Historically, there has been removal of total menisci, as in meniscectomies, and this has led to early degeneration of the areas where there's no cartilage shock absorption, and this is one of the post-op complications that is reducing due to the more conservative style of surgery. Mechanical instability may also be lost due to this loss of congruency within the tibiofemoral joint. Management of post-op or partial meniscectomies is following the excision, reduction of the swelling primarily with RICE, re-education of the quads, so where there is inhibition due to pain or swelling, these may need to be re-educated from a non-weight bearing to a relative weight bearing position, and some addition of walking aids as necessary in the early post-op period. Pain control, restoration of mobility, strength, re-education of function, including not only strength and mobility, but also proprioception to improve the stability around the knee joint. Following repair of the menisci, then the very similar pattern to the above, but you must be more conservative, as repair of the meniscus if the tear was in the vascular zone, they need to have less stresses particularly rotational stresses put through. Sometimes the site of repair will determine how conservative rehabilitation should be. Non-weight bearing to partial weight bearing immobilisation for 3 to 6 weeks is common. However, each surgeon may have their own regime according to the return to full activity in sport is usually within 3. Other types of meniscal dysfunctions may include cysts of the menisci and a discoid lateral meniscus. Cysts of the menisci usually occur in the lateral meniscus, as discussed previously, because of the loading, and often have some sort of trauma. They occur in the outer zone, and patients often complain of localised intermittent pain with a palpable lump across the joint line. MRI will confirm the diagnosis of cysts. The discoid lateral meniscus is an anatomical variation, and instead of the meniscus being semilunar in shape, it becomes rather more discoid, and this increases its susceptibility to injury. There may be symptoms of locking or snapping of the knee. There are other dysfunctions associated with the meniscus. These can be injuries of the small ligaments that control the menisci, such as the transverse meniscal ligament and the coronary ligaments. The transverse meniscal ligament is commonly seen and injured in hyperextension injuries, where there's been a definite snap into extension, and these can be successfully managed conservatively. Injuries of the coronary ligaments are seen with tender points across the joint line, and there won't be any locking or giving way, such as seen with meniscal injuries. Again, these can be successfully managed as with any ligament